I tried to figure out what credentials I have to speak to a neuro group. And my contact with pediatric neuroradiology actually started when I was a medical student, even though I wasn't aware of it. I received the award, the Derek Harwood Nash Award, for being the most successful student in surgery at medical school in Johannesburg. It was given by Derek and his sister in memory of his father, who was a surgeon and who died at a very early age. At that time, I didn't know who Harwood Nash was, and I didn't really care. But some years later, it was very useful to have the Harwood Nash Award in my CV when I applied for a pediatric fellowship at Toronto, and then when I obviously applied for the staff position, because Derek was the person who gave it to me. So I was very fortunate. Working in Toronto with a very strong group of pediatric neuroradiologists reminds me every day, of course, that MR is the gold standard and that ultrasound is something that comes along behind. But despite the fact that ultrasound does not show everything as clearly as MR, it still is requested on a daily basis because children are maybe too sick to go to the MR, or the MR is not immediately available, or it's the wrong timing for the MR. So it's something that we have to do on a daily basis. And if you're going to do something, you might as well do it properly and get the most out of it. Now, I've been involved in head ultrasound for a long time. I hadn't written much about it, but when Monica Eppelman, one of our fellows who's now in Orlando, came to our department, we got talking about different things that we were doing in head ultrasound, and she got very interested in trying to set up a study that would compare what we were seeing on ultrasound with MR, and that helped us a lot. I first went to Caffey's textbook on pediatric radiology and was shocked to find that there was nothing on head ultrasound in the term neonate. It disappeared from the pages. The only thing that was there was MR. And when we reviewed the literature, we found that the studies comparing MR and ultrasound were really very deficient. First of all, they were all retrospective studies. In many, there was a long time interval between the ultrasound and the MR in the same patient, sometimes up to 2 days. The ultrasound exams, the images were really not state-of-the-art, and nobody was showing images with linear array transducers. There was no Doppler. And what amazed me was that many of the articles that had been published did not actually show ultrasound images. Or if they did show ultrasound images, there were far fewer than MR images. Here is an example of a patient who is evolving. You can see at the beginning here with this sulcus, there's no lesion around the sulcus. 2 days later, you can see there's an echogenic structure there in the coronal and sagittal, and this correlates with the MR done within a few hours. So if you're going to compare this MR on the right with the ultrasound all the way here on the left, of course ultrasound comes out looking bad, but if you've got the ultrasound close to the MR, the ultrasound looks a lot better. In this patient, I came in one morning, and one of the other people involved with this study, Christian Kellenberger, who's now in Zurich, showed me this case. It's actually projecting quite well. I don't know if anybody can see where this gross abnormality is. I looked at the ultrasound, and I wasn't quite sure, and I was a little bit hesitant, and he said to me, absolutely, there was a big lesion there that he had seen on real-time imaging before he had looked at the MR. All of this study was done blinded to the MR. And there you can see the changes on the MR, and if you look at the ultrasound, the changes on the ultrasound are there. You can see here, here, and here, correlating with the MR. And the advantage that he had was that he was doing it in real time. That was a disadvantage I had because I didn't do it in real time. But it emphasizes that if you're going to make a real comparison, you have to actually get in there and do the ultrasound and look at it in real time, because you'll often come up with more information. Now, this is a statement I found in a a paper some time ago. It says that the white matter, WM is white matter, echo densities and echolucencies were emphasized in the study. Abnormal periventricular echo density was defined as abnormal signal intensity in the periventricular white matter with signal intensity characteristics greater than those in the choroid plexus. It's nonsense. It's absolute nonsense. It's a combination of words that relate to radiography, to CT, and to MR. And it's not the way we talk in ultrasound. So if you're having a study like this where you're comparing MR and ultrasound, you cannot but help to go away with the feeling that these people who may be able to do the ultrasound very well, are very biased in favor of MR. You might say, well, give these people a break. They're probably not English speakers. They're English speakers. And in fact, you might say, well, you know, it was published in a second-rate journal. It was the American Journal of Neuroradiology in 2003. And you wonder, you know, who were the people that were reviewing this? The reviewers obviously didn't pick it up, and they obviously must be a little biased as well. So the papers that I've written with Monica Eppelman relate to the study where we tried to look at a comparison of ultrasound and MR performed within 2 hours of each other. The ultrasound radiologists were blinded to the MR and the clinical findings, and the ultrasounds were analyzed prospectively. We never changed our opinion after we had seen the MR. It was proved by the Research Ethics Board, and we got informed consents for all the ultrasounds that were not indicated. Now, I'll show you this slide here because the title of my talk is How I Do It, and we'll come to some of the truth of that a little later. But this is a slide I use for all of my talks on ultrasound. Doesn't matter whether I'm looking at the spleen or the kidneys or whatever. So compression of the gas, you can exclude that. But the point is, as a sonographer, and even if you're not a sonographer, this is what you should expect from the people who are doing the sonography. They should have flexible techniques using as many planes as they can. So use any fontanelle you can, or any bone, if you can go through a premature baby through the bone or the mastoid region. The patient positions is very important. I sometimes say to a tech or a fellow who's done a study, why didn't you get this? And they say, well, I couldn't move the patient into a specific position because the nurses were there. So we have to negotiate our ways with the nurses and explain to them why we need to change positions of the head. What's very important are the transducers. The vector and curved array transducers are great for geographic depiction of structures, but the linear array transducers, particularly the higher megahertz transducers, will show you a lot of detail in small areas, and that hasn't been emphasized a lot in the literature. What we like to do, again, whether it's the spleen or the liver or kidneys or whatever, soft tissues, magnify the images. Put the focal zone in the area of interest. You don't want the focal zone right at the back of the image and you're trying to look at something up at the top. And every now and then I think Doppler can play a role. So the protocol we had was to optimize the resolution and depth and penetration. We used both sets of transducers, the sectors to get the geographic look and the linear for the detail, multiple windows, angled views. You have to angle the transducer. It's no use just moving it around. You have to angle it through whichever window you get. And then we got focused views, particularly with the linears, and I'll show you these, of the gray matter, white matter, the basal ganglia, corpus callosum, and whatever. So when you look at an image, you want to see the brain itself. You don't want to just see the outline of the brain. You don't want to just see the midline and the ventricles. You want to see the brain parenchyma itself. And here is some high-res imaging with a linear array transducer of a premature baby, very smooth brain. And you can see these linear markings in the brain that haven't really been illustrated much in the literature. And we think that these probably relate to the medullary veins, and corresponding here to this diagram from Wigglesworth's book. Here is another premature baby with lots of hyperechoic foci. You might say, well, this is obvious intracranial calcification, maybe from a torch infection, but many of these calcifications are linear, very similar to what I've just showed you, the vessels. And you don't usually see vascular calcification to that degree in the brain in neonates. And when we see this, I always say to the tech or the fellow who's doing it, please go get another scan 20 minutes later, and you can see everything's gone because all of this is just air embolus in the brain. Now, one of the problems that I still have, and I'm showing these images on this case from a long time ago because I think they're valid and I don't think we've made much progress in solving the problem, is what constitutes increase in periventricular echoes. People refer to this flare around the ventricles, particularly neonatologists. Here's a patient on the 23rd of August. You can see that there's some periventricular echoes, which I would call normal. You can see on the 14th of September, there are some hyperechoic foci that are more echogenic than the choroid, and they're patchy, they're heterogeneous, and they're asymmetric. And that's the sort of thing I look for. They have to be heterogeneous, they have to be hyperechoic, and usually asymmetric before I like to call them periventricular ischemia. And here you can already see some leukomalacia developing. It gets even worse later in the month, and then in the next month you can see what's happened to the brain. The problem with this is twofold. Number one, I think we often do the ultrasounds at the wrong time and we're not seeing the hyperechogenicities early on. And secondly, I think we are still underestimating the amount of abnormality on the ultrasounds that will be better shown on MR. As far as full-term babies are concerned, you read in the literature, in the textbooks, about increased echogenicity of the brain. And if you look at ultrasound descriptions of abnormal kidneys in neonates with ischemia, people write that the kidneys have got increased echogenicity. To say that something has increased echogenicity, you have to have a baseline to refer to, and in the brain, in the intracranial area, there's really no other structure to compare it to, so you have to look for other things. So if you have a patch of increased echogenicity like this over here that extends a long way, that's simple to see. In this one, you compare the two sagittals over here. The right is normal, the left is a little more echogenic. You can see it over here, it's a bit more echogenic here. That correlates with an area of ischemia in the middle cerebral artery distribution, and again, it's quite subtle. The images are not, they show the abnormality, but I wouldn't say they're wonderful. They're pretty big geographic images. You need to see smaller parts of the brain. And this is what I like to teach, is that when you look at the brain parenchyma, look at the linear images that show you the sulcus and the gyrus. The white matter tends to have these hyperechoic foci that are not very well packed together, and there's not a great demarcation between the gray and the white matter. The echogenicity seems to go sort of get a little less as you get into the gray matter, but there's no sharp demarcation. When there's ischemia or edema in the parenchyma, you can see the white matter becomes hyperechoic, and the gray-white differentiation starts to become a little better seen. And I think that's a very useful, subtle sign on ultrasound. It's most useful, I think, in the parietal region. It tends to be a little bit more difficult to evaluate at the back of the head in the occipital region, because sometimes when you're coming in from the anterior fontanelle, you will sometimes see some of the gyri appearing to have a sharp demarcation normally. But in the parietal region, when you see this, it's definitely abnormal. Here it is again. Here's the normal, and there's the abnormal. Note that the gray matter, when you're having a magnification at this level, the gray matter is not completely anechoic. It's not black. There are some low-level echoes normally in the gray matter. Even with older transducers, you can see the same thing. Here is an old transducer showing you the normal white matter and gray matter, not sharply defined, but look how sharply defined it is over here. So when you see that, that's definitely abnormal. This actually was this sign was the reason why Monica Eppelman and I got involved with that study to correlate CT and ultrasound. And in fact, when we looked at the literature, we found that Peter Winkler, who was a pediatric radiologist from Germany, and who I guess saw the light and became a neuroradiologist, he actually has a paper way back in 1998 in which he said infants with extensive white matter disease, the corticomedullary differentiation is considerably enhanced. And he didn't have many cases to show. It was a small paper. And I think he was the first one to actually describe this, what I think is a very useful sign. Here you see a more marked degree of involvement of the brain, and when this happens, the brain starts to lose anatomical differentiation. This is, I think, the more gross example of when the brain starts to be called hyperechoic, and the gray and the white matter seem to flow into each other. Here again, without well, in this one there is some gray-white differentiation that's sharp, but in other areas it's very poor. So there is a spectrum of changes in the parenchyma that one can see on ultrasound, and I think one has to understand this spectrum and not just refer to it simply as increased echogenicity of the parenchyma, and you have to do these high magnification, high resolution, high megahertz images in order to see it. There is one example here of the opposite occurring, where the cortex and adjacent white matter is hyperechoic, and the gray matter here is grossly abnormal. And you can see that over here, and that correlates with this abnormality on the MR. You can see the very nice correlation around the gyri. We also look at central structures, basal ganglia, brainstem abnormalities. I showed you a case where there was an abnormality, a very subtle abnormality on the left. Here is one on the right where the thalamus and the basal ganglia are involved, and you can see the correlation is very nice. In this one, you can see that there's quite marked diffuse white matter abnormality even on these geographic vector scans or curved array scans, but you can also see that the corpus callosum is markedly increased in echogenicity, and that is an abnormal, definitely abnormal corpus callosum that's involved. Sometimes the corpus callosum on these geographic images can look completely normal, but when you blow up the image and magnify it, you may be able to find a small hemorrhage, as you see over here, correlating very nicely with the MR. Here is another small hemorrhage in the anterior parietal region, correlating with the ultrasound and MR very well. Last one I'll show you is of the brain stem. Here's a normal brain stem in axial with the aqueduct here, the cerebral peduncles and the quadrigeminal plate, and in this one you can see there's a marked asymmetry of the peduncles correlating with the abnormality on the MR. Doppler, we don't do regularly, but in this study that we did find Doppler abnormalities that have been described previously, that with ischemia, asphyxia, particularly in full-term babies, the resistive index goes down. The flow velocity during diastole goes up, so the resistive index goes down. That was not something new that had been described some time ago. And if you do the same vessel, here the anterior cerebral artery, at two different times, you might find that the resistive index is different. And this is felt to be due to a loss of autoregulation circulation and fluctuations of cerebral blood flow. The other thing that one can see, which is much more subjective on ultrasound, is hyperemia, and you can see the large amount of vessels here in the thalami particularly correlating with the large vessels on the MR as well. But this type of Doppler really is very subjective, and we haven't done any studies to try and standardize it yet. Now, the study that we did was on 70 patients. We had a sensitivity of 100% and a negative predictive value of 100%. We thought that this was pretty good evidence that ultrasound could correlate with MR. There were 6 patients in that group in whom the ultrasound was positive, but the MR was negative. And I'm not brave enough to tell you people that ultrasound is better than MR, but I don't know the explanation for that clearly. What we then did was, this is the one I've just shown you, we then took 43 neonates and looked at them retrospectively before we did that study that was controlled when we did the ultrasound and MR within 2 hours. And you can see here the sensitivity and all these numbers drop quite significantly. So if you're looking to see what the correlation is, you have to have this kind of work in your department. You can't simply rely on this. Now's the time for me to tell you some truth, and the only reason why I'm going to tell you a bit of truth is because some of our current and some of our previous fellows are sitting here, and if I don't tell you the truth, they will have something to say to me after this. But we do not function at this level on an everyday basis. It doesn't happen. We don't have the time to go from ultrasound to look at every case in real time in the NICU. We have a bunch of extremely experienced technologists, and the technologists do scans that include linear array transducers, and I'm sure the truth of what is happening in our department will be somewhere in between these two studies at the moment. I believe that we are very much better than this over here. Because of doing the study, we changed the way in which we did things on a routine basis, and I think it has helped us dramatically to improve the quality of the exams that we do. So in order to get optimal results, you should be looking at the images in real time, not just the static images. You have to use the vector, curved, and linear array transducers with a high megahertz. You want to use multiple windows with focused views, the magnified views, and the focal zone in the correct position, and sometimes Doppler can be of help. Two things I'd just like to add to what I've just said is, the first one is the situation of the cerebral venous sinuses. Elke Miller, when she was in our department, did a study looking at the sinuses prospectively. One can see the anatomy of many of the sinuses, and they can correlate with the MR quite nicely. It does take more time to look at the sinuses. You have to have different views to look at all the sinuses carefully, and we don't use this as a routine, but in specific cases, or if you're trying to solve something like an MR that doesn't show one of the transverse sinuses, the ultrasound is often extremely helpful in showing you flow in both transverse sinuses. In this patient with multiple hemorrhages in the parenchyma, there was a huge thrombus in the sinus over here on the left. This is the part of the lumen, and that you can see it's an echogenic thrombus compared to the opposite side, the right side, and here the left side is with a little bit of flow around the thrombus, and here's the normal right showing you good flow, and there's the MR correlation. So I think looking at sinuses with ultrasound is a problem-solving tool. I don't think it's something that you have to do in every single patient. The other thing is looking for subdurals. I think subdurals can be extremely difficult. You have to look as best you can with linear array transducers in the near field. As you see over here, we've cut down this big view of the whole brain, just looking at the near field. And in this one, you can see that the vessels are trapped here against the brain by the fluid in the subdural space. Again here, just magnified and correlating with the MR that was done subsequently very, very nicely. I'm going to stop there. I would just like to say one other thing about Derek Harwood Nash. In the early days when we started ultrasound, he was extremely supportive of our department getting involved in ultrasound of the brain. And in fact, we had a political interaction with the neonatologists who thought that they were going to be the ones doing the ultrasound. Thank goodness for Derek that he won the battle and kept the ultrasound for us. I think what happened 30 years ago is a good lesson to what's going on in ultrasound today, where everybody in the hospital thinks they can take an ultrasound and wave it over a patient as if they're using a magic wand. People think that the ultrasound is the stethoscope of the future. I don't think it's that easy. I think we need to keep ultrasound in the hands of people, imagers who are properly trained to use it. I wish more neuroradiologists would be doing the ultrasounds because they know the anatomy far better than we body imagers do, although we are the ones who tend to do it in North America most. And I think that we need the support of neuroradiologists and everybody involved in imaging to keep it in our domain. Thank you very much.
Thank you, Dr. Danman. We'll now open the